Welcome to Transfusion Practitioners Across the World, podcasts for TPs and other transfusion professionals to talk all things blood transfusion.
Hello, everybody. Welcome to the ISBT podcast, Transfusion Practitioners Around the World. Transfusion practitioners have expertise in many different clinical specialties, and this is the third podcast in this series talking to transfusion practitioners working in those specialist areas. Today's episode is about transfusion in paediatric and neonates. My name is Claire O'Reilly, and I am a member of ISBT. I'm also a transfusion nurse clinician at British Columbia Children's and Women's Hospitals. I have a long background in pediatrics and transfusion practice, having worked administering blood at the bedside, collecting blood for autologous, collecting platelets, and now my current role as a transfusion nurse clinician. And I'll now hand over to Rachel.
Thanks, Claire. I'm Rachel Moss. I'm a transfusion practitioner at Great Ormond Street Hospital for Children in London. I've been here 8 years, but I've been a transfusion practitioner for over 20 years now. And I'm also chair of the ISBT Transfusion Practitioner Group.
As Rachel and I both work in pediatric and neonatal hospital setting, we are going to talk about all things transfusion in this specialty. We are fortunate to be able to bring this podcast thanks to the support of the International Society of Blood Transfusion, known as ISBT. ISBT is a global community of professionals sharing knowledge to enhance transfusion practice and blood management. The Society does this by providing opportunities for advancing knowledge and education and by advocacy for the welfare of donors and patients. ISBT has many working groups that focus on specific topics or areas of practice, and one of those is the transfusion practitioner subgroup. If you are not sure what transfusion practitioners are, you may want to go back and listen to our first podcast, What is a Transfusion Practitioner? So we'll get started on the discussion. So a frequently asked question is concerning the unique challenges related to neonatal and pediatric transfusion. And these are a very specific group of patients, not just mini adults or little adults as many in the adult world refer to us by. And we have many challenges, especially to do with three specific groups to manage. At our site and at Rachel's, we have neonates who are up to 28 days of age and includes very extreme premature babies, infants up to 1 year, and then children from 1 year up to 18 years at my facility. I don't know how old children go to Great Ormond Street until, with great variation in size and needs. Now, there is a lack of evidence for neonatal and pediatric transfusion medicine in comparison to adult transfusion medicine. However, in recent years, there has been an increase in research, and we will include a list in the reference section for this podcast. And of course, we must mention that the ISBT Pediatric Subcommittee is working on 2 neonatal and pediatric related publications. And at all the ISBT conferences, there are always fantastic sessions on neonatal and pediatric transfusion. Specialized transfusion requirements for different age groups is part of the course in our setting. For example, fresh blood, either less than 7 or 10 days old for our neonates, and irradiated components for our extreme premature and premature neonates and oncology patients. In Canada, we do not require CMV components for our neonates. I know we differ from other countries in that respect. And of course, the volumes that is transfused are very low, as low as 10, 20 mils. And therefore, we need to educate physicians and nurse practitioners on the importance of vigilance when ordering blood components and to order in mils for neonates and infants and small children, and then switch to ordering in units for children, older children and teens. We also educate nurses and other healthcare professionals to be vigilant when administering blood components. The pre-transfusion checks involves checking the volume ordered, the volume issued, and a double check when programming an infusing device, because in the neonatal pediatric setting, we always use infusion devices to ensure we can deliver precise volumes. It is critical to avoid overtransfusion, which is an added risk for neonatal and pediatric patients. And this work is also involved in when we're switching to electronic ordering and making sure that these systems have built-in safety checks. At BC Children's and Women's, where I work, I'm fortunate that we can issue the exact volume for our very small neonates. So if the volume is less than 50 mils, it's issued in a syringe aliquot and it's pre-filtered. And then for smaller children, we issue aliquots in mini bags. In areas where it's not feasible to do so, nurses may aliquot at the bedside. And this involves a lot of education, especially in hospitals where you have a pediatric hospital within a larger hospital, and staff may not be as familiar with lower transfusion volumes than in a pediatric or neonatal hospital. We also involve our families in decision-making and the informed consent process. Parents of neonates and very sick children are frequently overwhelmed when they're faced with the knowledge that their infant or child needs a transfusion, and then the need to give consent for transfusion. So we really walk with our families through this decision-making process. And of course, tied to informed consent is the right to refuse transfusion, and this in turn requires compassion and understanding. So Rachel, over to you.
So even just listening to the first few minutes of this, we realised just what a specialised area we're working in. And Claire's talked a lot about volume, so I'm just going to go on a bit more about that, because one of the issues perhaps that I encounter constantly in paediatrics is this volume of blood. And as you say, Claire, it occurs in our specialised paediatric centres, and so we know it's also a big problem for paediatric units within adult centres. So we haven't really cracked this. And what we found, certainly at Great Ormond Street, and I think this might be suitable for something that paeds across the UK, is this blanket 15 mils per kilo. So regardless of what we're aiming for, particularly with red cells, that we seem to just issue or request 15 mils per kilo, sometimes up to 20 mils per kilo. I've even been asked for 25 mils per kilo. Now, we're not talking about a bleeding patient here. We're often talking about top-up transfusions. And one of the points to say, in adults, we usually transfuse about 4 mils per kilo. So we're talking 4-5 times what we would do in an adult for these very small babies. One of the things we're trying to do in the UK to tackle this, and it's in the British Society of Haematology Paediatric and Neonatal Transfusion Guidelines, which are currently being reviewed, is to use a formula for the calculation and prescribing of blood, and this can be found in the BSH guidelines. But the purpose of it is to take the desired hemoglobin, look at the actual hemoglobin, and then do the formula in relation to the patient's weight. And so we think this is a more scientific approach to a top-up transfusion. Also helps with the laboratory scientists, because they often are given strange volumes for small babies, take them to think about what would be a sensible volume for a small baby. And that's just with red cells. We know that there's also issues with platelets and plasma, and often little evidence to show why we're using them. We know there's some issues about restrictive transfusion. And we all understand that the struggle is real to minimise donor exposure. One of the conversations we have is it better to over-transfuse and give fewer donors, or give less volume, which is what we're talking about here, but then there's a risk that we could give more donations. Transfusion practitioners are crucial to this, because we need to support the decision making. We need to have processes in place that our clinicians understand. And I do know that certainly in adults, over-transfusion, and let's mention TACO here because it comes up in all conversations, ISBT, Canada, the UK. So let's talk about TACO in children. Most of you, but not all of you, will be aware of the UK Haemovigilance Scheme called SHOT, Serious Hazards of Transfusion. And SHOT review the data. And actually in children, there are very few reports. We've got quite a lot in adults, but very few in children. 5, I think, in the last few years. But we don't think that's because it doesn't happen. We think that's because it's underreported. We know we've already said, these children often have lots of other things going on, they're very complex, and actually we may not necessarily realise, or our clinicians may not necessarily realise, that the reason why the child is becoming unwell is because they're over-transfused. So again, as transfusion practitioners working in these areas, we make sure that our clinicians understand TACO, understand over-transfusion, understand volumes versus weight, so that everybody understands what we're trying to focus on when it comes to small babies and how much blood we give, or even younger children and how much blood we give.
Thanks, Rachel. TACO leads nicely into talking more about transfusion reactions. And I will share that as part of the education at our site and in our procedures, I do include a step for the pre-transfusion assessment, and in that give steps for how to look for signs of volume overload before the start of the transfusion. And I think that falls nicely in with the shot TACO checklist and trying to adapt that to the pediatric setting. Children react more frequently to plasma and platelets compared to adults. And for many years, I suspected that pediatric patients were reacting more frequently, but I didn't have any evidence to support my suspicion. And unfortunately, the Canadian data did not differentiate by age. This was disappointing. So I requested our provincial data. So that's the transfusion reaction reporting for the province of British Columbia for 5 years. And this data indicated that pediatric patients had more minor and severe allergic reactions to platelets and plasma. And data from Ontario, Canada and the SHOT report have also had similar findings. And it's vital to have this information for our patient population, in considering this information when creating policy procedures and education for transfusion, patient monitoring and transfusion reaction reporting. At my site, we have many patients who have multiple adverse reactions, and we work with the patient and their families to manage anxiety and develop pre-medication plans. For example, we avoiding sedating antihistamines for some of our teenage patients who want to study. They're very diligent. They want to be able to study when they're in the clinic, and they were not reporting when they had signs of a reaction because they didn't want to get the antihistamine. And for our very young patients, because we want to avoid napping at the wrong time of the day and end up with sleep disturbance. So we really do work closely with our families in these situations to manage their transfusions, knowing that they have had frequent reactions. Traceability and accurate transfusion histories are also critical for our patient population because they go on to have a long life ahead. So knowing that a neonate received a transfusion in hour 1 of life is really important, because hopefully they will go on to live well into their ease, and we need to have that accurate history. So a lot of our work as transfusion practitioners is to educate staff on following processes for confirming transfusions. At our site, we're not fully electric, so this does not happen automatically, and reporting all transfusion reactions to ensure vein to vein. Now, Rachel, I know you're really keen to talk about patient identification.
Yes, I will say that I agree with you. I think children do react a lot more, but yeah, I think I once said they react to everything, but that's probably a sweeping generalisation.
It feels like that.
So yes, I will talk about the children and patient ID bands, and we know that this is a very unique group. Let's talk about neonates first. Wearing a patient ID is such a struggle. They're so tiny, their skin is so fragile. It rubs when you see him lying there, and the manufacturers of identification bands don't always make the best for our very small babies. We have seen some really, really soft ones, and I've been sent examples, but they don't go through a printer, and we use a patient electronic record, and all our wristbands come printed through our EPR, and the electronic patient record has those long strips of paper ones which are quite hard, so they fall off or they really rub, and we don't have a solution. And different people will often say they use different ways. Maybe that's on a cot, or that's on a bed, or that's on some oxygen tubing, but it's still not ideal because they're the most vulnerable group. And you know, with the greatest respect, neonates look much like more other neonates, and so it's very difficult necessarily if the parents aren't there. But then let's move on to older children who hate them. They really hate them. And if you're in for a long time, particularly let's think about bone marrow transplant patients, or let's think about our oncology, hematology, or our renal patients, the nursing staff know who they are, they're very well known to your hospital, they'll come in all the time, and they also think that they're slightly irritating. And then of course parents cut them off, because if you really have an unhappy child and one of the things that's irritating them, they can cut them off. And it's an ongoing issue, because it's fine if they're not going through any transfusions or medication, but I think that would be in an adult situation. We would never give a blood transfusion or medication to an adult not wearing a wristband. Yet in children, we seem to feel that they can be identified by their parents. We've tried to help as much as we can at Great Ormond Street by having a photo ID on the electronic patient record, which on paper sounds very sensible, but appearances change due to illness, changes due to growing up. If you come in here aged 2 months, you're going to look very different even at 6 months. And the problem with it, of course, is if you've got something on a computer record, it can be managed away from the patient bedside. So it is not without its risks. I've already said that you might put a wristband on a cot, or perhaps you might put tape rather than a wristband. Others put it on the IV cannula, so where you tape up the IV cannula, that has the patient's information on it, but that of course has to be changed every time the cannula is changed. Whatever system is used, positive patient identification in this patient group is critical for patient safety. Going back to SHOT, we did a webinar on patient identification in this group earlier on this year, so this is 2024, and I would encourage anybody that's interested to go back and listen to it. We also got a young person from my hospital to talk about why, as they get older, they actually do understand that wristbands are critical and how important they are. So I don't have an answer, but just wanted to bring it up because I think it's a very important part of managing paediatrics, and as transfusion practitioners, something we get asked about a lot.
Well, we share your pain here at CNW. Our audits have shown very low compliance with wearing of ID bands, and fortunately the staff have really been working with us to improve that. I think another thing to share as well, Rachel, is for neonates. In our neonatal unit, you could have multiple baby boy Lees or, baby girl Sahoda, and we have multiple births. Twins and triplets are not uncommon, and these patients will have the same date of birth because it's your set of twins or triplets. And our MRNs, our medical record numbers, are sequential. So that means that if the last number ended in was one, the numbers are very similar. So patient identification is really critical. And we had a system that was cutting off part of the first name. And so it might cut off baby boy if the surname was long. So it's like, no, we can't be told to use a system that is chopping off part of the patient's name. So patient identification is a universal challenge. So another unique challenge or aspect is that our patients are maturing during their treatment, and this impacts their care. So our chronically transfused patients transition from infant to older child, then teenager, and eventually a young adult. And this impacts how we share information about transfusion and how and when we involve them in the decisions around their care. We need to create patient information that is suitable for different age groups. Our chronically transfused patients become more involved in decision making as they grow older and may eventually sign their own transfusion forms. And we may also at certain times have issues with compliance with care during those turbulent teenage years. And we've already addressed the issue of wearing ID bands, etc. And our staff needs to adapt to how they communicate and interact with patients and support them appropriately. Age-appropriate care is fundamental for caring for pediatric patients. And during a recent major project in Vancouver, when we went to electronic order entering, it was extremely frustrating for the informatics team that there was no standard dose, standard volume, standard anything for our patient population. I remember somebody say, well, what's the standard volume of albumin? And it was like, well, there isn't. So these patients start off having their transfusion ordered in mils, and then they go on to full units, and it may be challenging.
So you've already heard that some of the things that is challenging, volumes, patient identification, transfusion reactions, information for them and their parents. So we're just going to slowly move this now to patient blood management, because we know a lot of the people that listen to our podcast obviously work right in the middle of transfusion settings, and PBM is now something that we're all very focused on. And it's an internationally recognised set of interventions, so we know that. It assists clinicians to make sure we give appropriate transfusion. But I think it's very important to say that these programmes cannot be universally applied to children, and there is current significant variation in transfusion practices. So there are physiological differences between neonates and children at different developmental stages, as there are between children and adults. And a frequent misconception is that neonatal and paediatric are the same. And I think Claire and I brought this up, that we talk about neonates and we talk about paediatrics, and they are separate specialties in our world. So let's use managing iron deficient anemia. This comes up quite a lot. We know in the adult population, certainly in the female population, is something that we focus on a lot, or in a preoperative setting. But if you're looking at why a 1-year-old has iron deficiency anemia, that's going to be a very different set of reasons than a young female who may have iron deficiency anemia because she's 13. And so we have to take that into account. So when you're looking at managing preoperative care, which we all do, and how you ensure that these things are picked up, it's very difficult. And we've reviewed this, and we actually have found that in the craniofacial patient cohort, there were patients transfused who had iron deficiency anemia. Now we want to try and catch these, and we are doing a flowchart for our clinical colleagues to follow. But we have to have arm shoots for everything. Is the child 1? Is the child under 1? Is the child on solid food? Is the child on cow's milk? Is the child on formula? Have they started their periods? All these things have to really be taken into account when you're looking at a child and why they may be iron deficiency. So there are a lot of not just logistics but variables that have to be taken into account. Another thing is blood sample taking. There is a school of thought that we oversample on a lot of children and we take unnecessary samples. That's maybe a discussion for another day. But what we do know is they are really at risk from iatrogenic anemia, particularly in our very tiny infants and neonates who may well be on a critical care area. And so monitoring their electrolytes and their hemoglobin and their coagulation status is crucial. Yet volumes, frequency of sampling, why are we doing the results? What are we hoping to get out of it? All these things need to be thought about. Is it nice to know what the hemoglobin is, or do we genuinely think it's going to change treatment? So we do focus a lot on the very small samples. One of the issues is, do these fit on your analyzer? So it's all very well having tiny little bottles for tiny little babies, but if they get to your laboratory and your laboratory can't process them, then they're a waste of time. So I've just brought up two different things that we think are. There are other topics, obviously, with iron deficiency anemia and iatrogenic anemia and other things, but for us in PBM, and Claire, just chime in at the end if you think there's anything I've missed, but I think they're the two ones that the struggle is real.
Yeah, I definitely think for the causes of anemia, again, because of such the wide age group, there are so many different causes for anemia, and considering the age group is really important. And if you have a child on a general pediatric unit as opposed to maybe a specialized pediatric setting, the reasons for that anemia may be missed. And it really is unfortunate to see where the first line is to administer blood before all investigations are complete in situations where the hemoglobin, whereas it may be low, is not at a critical level. And also then the prescription of multiple units, and is hitting a little bit back on what we touched on earlier. At our site, we've definitely seen improvement with physicians ordering, if they want to order 20 ml per kilo, but they work out their calculation and divide that into multiple transfusions, and we can split a unit here, so we reduce donor exposure. But in managing anemia in these patients, transfusion may not be needed, and more conservative methods are required. And yes, iatrogenic anemia and sampling, we had some rogue practices at our site where people would collect a group and screen every time they collected a CBC sample, complete blood count. I'm not sure what the correct terminology is in England, I forget. But then the hemoglobin is fine, and so they don't need transfusing. And some people were really upset when the new electronic order system didn't facilitate that. And we said, definitely it doesn't facilitate that. So we do work with staff to ensure that there are no unnecessary draws.
Brilliant. So, I mean, we could talk for hours, but we're very aware that time limited.
I think
so
we forgot
we'll
to share, Rachel, how much fun it is to work in this environment. We wouldn't want our listeners to be discouraged from working as a transfusion practitioner in the pediatric or neonatal setting. It's an amazing setting to work in. I don't think I'd cope very well in the adult world. So yes, I think we should share that.
Brilliant. Thank you, Claire. So we've both really enjoyed sharing our experiences with you today. We have highlighted how complex and nuanced this transfusion patient group is. Neonates, paediatrics, we've already said under 28 days, up to the age of 1 and above. Very complicated, but fun and interesting. We've created a list of references that we've thought about when we're putting this podcast together, and they'll be listed on the website on ISBT under the podcast link. Just to say thank you so much for listening to us today. If you have joined us, we hope you have any feedback. If you've got any questions, then please do use the link or visit us at ISBT website. Check out the Clinical Transfusion Working Party, and under that you'll find more details about the transfusion practitioner subgroup. So we'd love to hear from you. We also hope you can join us at our next episode. So until then, from Claire and I, thank you very much for your time and thanks for listening.